Hello and welcome to this first episode for 2026 on the Pallium Canada's Journal Watch. Welcome. It's always exciting to do the first one every year, and especially exciting if it's in January and early in the year. It's hard to believe that this has been going now for 4 years. We've been doing this now for 4 years, and there's a large readership that's been developing not just only across Canada but also across the world. Now, usually during these live sessions, some people participate, and for those of you participating, welcome and enjoy. Today, we've got only two panelists, so perhaps there's more opportunity to make comments and ask questions. But what happens is these are recorded and then they're put online at the Pallium Canada website in the Echo project, and are made available for downloading afterwards. And a lot of people, hundreds of people, actually download it afterwards. And it's also transformed into podcasts. So again, on the same website, you'll be able to see the download previous episodes podcasts. First of all, just a very quick introduction to the Journal Watch for those of you who may be coming to us for the first time. This is a resource that helps people, especially those interested in palliative care, not just palliative care specialists, but actually healthcare professionals and colleagues from many different specialty areas and uh, care settings who are interested in palliative care, and this helps them be kept up to speed with the latest literature. So a team of academics, palliative care academics across Canada from different universities, including the University of Calgary, University of Alberta, Queen's University, as well as internationally. Myself here at University of Navarra in Spain, and a colleague at Hadassah Hebrew University in Israel. We keep track of just over 30 journals, and then with the support of a palliative care team, uh, folks submit articles that they think will either change the way we approach a topic or a treatment, or an understanding of a concept. And as an editorial board, and there are four of us, Dr. Leonie Herks, Dr. Aingaran Sinaraja, Dr. Sharon Watanabe, and myself, we then go through the submissions by these different teams, and we select what we think are the top four, and we present those top four, which we'll be doing this today. And we also present a list of between 3 and 5 honorable mentions. So these are articles that we think are worth attention, but we wouldn't have had the time to present them. So that's a bit of a background. And then obviously, as I said, these are recorded. They are shared for viewing through a channel such as YouTube, but then also turned into podcasts. I'm a professor in the Faculty of Medicine, and in the Institute for Culture and Society at the University of Navarra in Spain. I'm also the scientific advisor and co-founder of Pallium Canada. I continue collaborating with colleagues across Canada, and those of you who know me, I spent over 30 years working in palliative care across different parts of Canada, including Edmonton, Calgary, Ottawa, and Hamilton. And with me is my colleague Leonie Herks. Leonie, over to you.
Hi, everyone. Nice to be with you again. I'm a professor of palliative medicine at the University of Calgary and scientific director of the Palliative Institute here in Alberta. And I've done pediatric and adult palliative medicine for almost 20 years. So glad to be with you today.
Excellent. So, as I said, we're missing our colleagues Sharon Watanabe and Aingaran Sinaraja, who are very busy with clinical work and couldn't make it to this episode. But they always, as usual, have provided input. So the input you'll be getting will be from the whole team. In terms of disclosures, Planet Canada is a registered charity. It generates funds to support this type of work through registration fees and license fees and sales of things like the Pallium Pocketbook, and also through philanthropy. We've got a team that is completely independent. We select the articles ourselves. There's no influence, there's no outside influence, there's no pharma involved in it at all. Um, I have no conflicts of interest to disclose for this particular journal watch, and neither does Leonie. So, with those introductions, Interestingly, Leonie, I was looking at this by accident. This was not intentional. We ended up with an episode where three of the articles relate to the topic of palliative sedation. And it wasn't intentional. It was sort of as it unfolded, as we selected, at the end, we realized that's what had happened. But we've also selected an article that we think is very interesting and highlights the importance of care of the caregivers, of supporting caregivers, of providing information, given their very important role in the care of patients with serious illnesses. So these are our four articles. And to kick it off, I'm going to turn over to Leonie. Leonie will be presenting the first two articles, and then I'll present the other two.
Great, thanks, Jose. Yeah, so interestingly, we have two articles that came out on the use of dexmedetomidine in palliative care within about 3 months of each other. So I'm going to go into more detail on each article, but I'm going to present them back to back so that we can save our discussion until after we kind of look through both of the studies. And I'll start with giving an overall background that applies to both articles. So if you're not familiar with it, dexmedetomidine is an alpha-2 agonist that's been shown in the critical care setting to be very beneficial in treating delirium. In fact, it's the only medication that's specifically indicated for treating delirium in the ICU setting. And it's shown a lot of promise for its use in palliative care as well. So, unlike what we typically use to treat agitated delirium in palliative care, which is typically medications with a sedative effect to address that agitation component, they end up leading to kind of a decreased interactability at the end of life, and which isn't necessarily consistent with a person's goals of care, especially if someone wants to be able to be responsive to family members and have as much interactivity as possible through until their death. And so finding ways to preserve that is why dexmedetomidine has become of particular interest in palliative care, because it's been shown not to have the same level of sedation as many of the other medications that are used both in the ICU and palliative care setting, including benzodiazepines, for example. So it provides relief of agitation, but in addition, has been shown to be helpful with pain and dyspnea, and actually has opioid sparing effects. And unlike other sedative medications, it doesn't cause respiratory depression. It's also been shown in more recent studies to be able to be used subcutaneously, but through continuous infusion, rather than just in the IV uh, delivery, which is given in the ICU setting, and has up to 90% bioavailability when given by subcutaneous infusion. Um, it does have some sympatholytic effects, including some risks of hypotension and bradycardia, but when given subcutaneously, studies have shown this to be fairly uncommon. And so there's some studies that have shown safety and efficacy of subcutaneous infusion without typical intensive cardiac monitoring that is done in the ICU setting. And so lots of interest in could this be a better drug used to allow preservation of interactivity and responsiveness at the very end of life when used to treat agitated delirium and even refractory symptoms such as severe pain and the use of palliative sedation. So to date, in terms of palliative care, there's been very few studies, just some single-arm trials with no comparators, and mostly case studies that have shown some benefit in its role in delirium. So hence the two studies that we're going to present now to give us some more guidance around how this might be helpful in palliative care. So the first study is by Tate and Ferguson, who are hospice palliative care physicians in New Zealand. And the title of the article is Subcutaneous Dexmedetomidine for Refractory Symptoms in a Hospice Inpatient Unit. And it was published online at the end of October in the Journal of Pain and Symptom Management, and it's coming out in hard copy actually in February. So the goal of this study was to assess the safety and effectiveness of dexmedetomidine given via subcutaneous infusion in a palliative care unit using a descriptive analysis of patient demographics, treatment characteristics, the effectiveness of the dexmedetomidine, and adverse events and safety factors. So the methodology is that it's a retrospective observational review of clinical records from a single hospice palliative care center in New Zealand. All patients who were admitted to that unit who received who received subcutaneous infusion of dexmedetomidine who were 18 years of age and over between the period of October 2019 to February 2024. If the dexmedetomidine was discontinued for at least 24 hours and then restarted, they did count that as a separate um, study number, and so we'll come to the results shortly. But mostly it was separate individual patients. The dosing was zero point 0.2 to zero point 0.4 micrograms per kilo per hour. And patients, of course, because it's a retrospective review, continue to receive any other medications that the attending physician deemed were appropriate for symptom management. The data that was collected to look at patient characteristics and demographics, such as age, length of stay before death. They looked at dexmedetomidine dosing and duration, adverse events, as well as the effectiveness that was measured of interactivity, and that the substitute measure for that was the RAS palliative, given at both baseline at 6 hours after the dexmedetomidine infusion, and then at 24 hours after start of the infusion. And they looked at qualitative charting by clinicians to understand patient status during that time in terms of symptoms and overall quality of life, and looked at changes in their opioid and midazolam infusions if patients were on those at both 24 and 48 hours after starting the dexmedetomidine. And then finally looked at whether or not the person went on to have continuous palliative sedation therapy. So overall, there were 29 patients who met the inclusion criteria. 4 were excluded because they were participating in another dexmedetomidine trial in the same unit. Overall, there were 25 unique patients with 26 different infusion events. So one person had 2 dexmedetomidine infusions given as described above. So at least 24 hours after stopping, it was restarted again. So I'll break down the key results in terms of demographics, dexmedetomidine characteristics, adverse events, and effectiveness. So first, in terms of demographics, of the almost 1,000 palliative care admissions during that time period, as we've just discussed, there was 25 patients who received dexmedetomidine infusions with 26 unique events, which comes to a percentage of 3% of patients who are admitted to the palliative care unit. Of those, almost all of them, 24 out of the 25, died while in the palliative care unit, and almost all of them had dexmedetomidine continued until their death, so 23 of the 24 who died. And the main indications for giving the dexmedetomidine were refractory pain in 92% of cases and agitated delirium in 50%. And the mean number of indications was 1.5 per patient. So it was often not just one indication, such as pain or delirium. There's often multiple reasons for starting the dexmedetomidine. In terms of the characteristics of the dexmedetomidine continuous infusion, the median length of duration was 4 days for the infusion. The main reason for discontinuing it was death, so almost 90%. There were a few patients who it was discontinued because they had significant improvement in their pain control, so 8%, or it was a bridge to establishment of more definitive analgesia, in this case, epidural analgesia, in 4%. So it was stopped once that was put in place. Other symptom management medications were used, of course, and there was a median of 2.5 different medications used after initiation of the dexmedetomidine. So the infusions of dexmedetomidine were started at 0.2 micrograms per kilo per hour. Of those 25 patients, 5, so 1/4 of them actually had it started at a higher dose at the 0.4 micrograms per kilo per hour because they had more severe symptoms at baseline. And then there were 2 patients who were felt to be more frail who were started at a lower dose, so 0.1 microgram per kilo per hour. And during the study period, the max dose, as per the New Zealand team's protocol for dexmedetomidine infusions, allows titration as needed up to 1.4 micrograms per kilo per hour. And 25% of the patients reached the max rate during the time period they were on the infusions. Only 2 patients of the 25 did not require titration of the dexmedetomidine above the initial dose. so less than 10%. So most people did. Clinician boluses of dexmedetomidine were also given, and it was at doses between 0.2 and 0.4 micrograms per kilo, mostly given prior to care or at times of increased agitation. In terms of adverse events, there was no serious adverse events observed in any of the charts. Dry mouth was reported in up to 58% of patients, and possible opioid toxicity in about a third. And that was described as decreased level of consciousness and decreased respiration rate. Of those people that were thought to have opioid toxicity, most of them had improvements when then their opioids were decreased in dose, with improvement in both alertness and respiration rate returning to normal. It's really unclear, as you can imagine from a retrospective review, whether any of these adverse events were at all attributable to dexmedetomidine infusions, but certainly important to note what patients were experiencing at that time. And there was also some subcutaneous site concerns as well, with about a quarter of patients who had the infusion. So they looked at a person's interactability through the Richmond Agitation Sedation Scale that was modified for palliative care. So at baseline for RAS-PAL, patients were on average +1 from RAS-PAL. At 6 hours after starting the dexmedetomidine infusion, the median RAS-PAL had decreased significantly by -1.5 change from baseline, and at 24 hours, also significant, had decreased by 2 points on the RAS-PAL scale. Only one of the 25 patients experienced an increase from baseline at 24 hours, which increased by +1 on the RAS scale. On day one, 88% of those receiving dexmedetomidine by continuous infusion were perceived to have effective relief of their agitation, as noted by chart notes by clinicians, but only 62% according to patients and families, and about 28% was not captured in the chart. 12% of patients who received dexmedetomidine it was perceived to be ineffective for them. Interestingly, 42% of those who received the dexmedetomidine infusions progressed to having continuous palliative sedation therapy after a mean of being on the dexmedetomidine of 4.6 days. Almost all patients had a reduction in opioid doses on day one, so 95%, and another 65% had further reduction of their opioid doses on day two. So the authors point out that, their retrospective analysis of all the patients in their unit who had dexmedetomidine infusions, it shows that it can be used safely and has good tolerability when used in the hospice palliative care setting. They described that the 23% of people who had subcutaneous site issues was similar to other continuous infusions given subcutaneously in palliative care, so it's not different than using other medications. That there was a clear opioid sparing effect with the dose reduction seen in the opioids in most patients in the first 24 hours, and further reduction seen on day two in at least another 50% of patients. That the decrease in RAS-PAL to a level perceived as being comfortable by clinicians was significant in the first 24 hours, but the patient and family perspective wasn't correlated because of a lack of information in the chart. And at least 40% of the patients progressed to needing continuous palliative sedation therapy after a number of days of being on the infusion, which the authors point out likely reflects the refractory nature of symptoms that required the dexmedetomidine in the first place. They did point out that in their palliative care unit, 11% of patients admitted during the year 2023, which was one of the years of the study period, went on to palliative sedation therapy. But as compared to over 40% of those that ended up with the dexmedetomidine infusion. So interesting, that was something we can think about for our discussion when we get to that point. So certainly some possibility of tachyphylaxis with prolonged use of the dexmedetomidine, and almost all of the patients ended up progressing to increasing levels of infusion over the 4.6 days of their median infusion rates. So the strengths of the study is that it's a large retrospective analysis of use of subcutaneous dexmedetomidine infusion in a palliative care setting. This is also its limitation, of course, because it's an observational retrospective design. We can't really draw conclusions on the effectiveness of dexmedetomidine, and we're relying on clinical documentation, which is often a proxy measure just by whatever information can be gleaned from the chart, and of course, no control or comparator group. It was also a single reviewer who did the data analysis from the team in New Zealand. So, of course, that introduces a risk of bias. And in terms of the author's impression of the impact on practice, I think we've covered most of it, that it's safe and well tolerated, but it may offer an intermediary step before palliative sedation for patients with difficult to control symptoms. And of course, further studies are needed, including prospective and randomized trials, which takes us to the next article, which is indeed a randomized trial. So this article is Thomas et al., who were out of Australia. And the name of the study is Dexmedetomidine versus Midazolam for End-of-Life Sedation, the DREAMS Non-Blinded Randomized Clinical Trial, and it was published in the Journal of Pain and Symptom Management in November 2025. So their research question was to compare the sedative efficacy of subcutaneous dexmedetomidine compared to midazolam in managing distress at the end of life in a palliative care context. Their hypothesis was that the dexmedetomidine would result in better rousability while maintaining comfort at the end of life compared to midazolam infusion. So it was a single center, non-blinded, randomized control trial of palliative care inpatients admitted for end of life care. At admission to the palliative care unit, they randomized patients one-to-one who were interested in being part of the study, should they need to have infusion started for refractory agitation. And so they kind of pre-qualified patients and then were able to enact the study protocol if they met activation criteria, which included having refractory symptoms that had failed other measures and death expected within 7 days. Their primary outcome for the study was responsiveness as measured by the proxy of RAS-PAL, as we've discussed, so a sedation scale specific for palliative care, in the first 72 hours after the infusion was started. The secondary outcomes were the severity of delirium, measured by the Memorial Delirium Assessment Scale, and comfort using the Patient Comfort Assessment. So the RAS-PAL was measured at baseline and then 3 times a day, each shift based on nursing shifts. The MDAS and the PCA were only measured once a day. The MDAS was also measured at baseline, but interestingly, the PCA comfort measure was not measured at baseline. The subcutaneous infusions were at set fixed doses. So dexmedetomidine was given at 0.5 micrograms per kilo per hour, and midazolam was given at 0.25 milligrams per kilo over 24 hours. They did use breakthrough doses of dexmedetomidine at an equivalent dose, 0.5 microgram per kilo, as well as midazolam, 2.5 to 5 milligrams. Both of them were allowed every 2 hours as needed, but to a maximum of 5 doses per day. Patients were withdrawn from the study as a failure of study protocol if they required higher rescue breakthrough dose use of either the dexmedetomidine or the midazolam, depending on which arm of the trial they were in, of more than 3 per day without any other cause. All other symptoms associated with their illness were treated as usual. So there were 52 patients randomized between the period of May 2021 and November 2023, 26 patients in each arm of the trial. There was a median age of 80, 63% were male, and most patients had cancer, 92%. In terms of the infusions, the average dexmedetomidine was given was 805 micrograms in 24 hours, and midazolam was 18 milligrams in 24 hours. The primary outcome, there was no significant difference in the mean RAS-PAL between the two arms. And on average, the RAS-PAL was -2 to -3, which is equivalent to light to moderate sedation, but some did fall below a -3, and there was note throughout the paper that there was significant variability with the RAS-PAL as measured in the way they did it, which was 3 times a day. The secondary outcomes for the delirium scale and the patient comfort scale both showed improvement in the dexmedetomidine arm and the midazolam arm. They noted that the delirium severity score decreased sooner, so within the first 24 hours compared to the midazolam arm. There was no difference between the comfort between both arms, but there was significant comfort improvement from day 2 to day 3 with dexmedetomidine and not with midazolam. And the protocol withdrawals were similar between both arms, but there was more people who withdrew earlier in the midazolam arm compared to the dexmedetomidine arm. So overall, the summary of this article is that neither the dexmedetomidine or the midazolam in this particular DREAMS trial were superior for responsiveness as measured by RAS-PAL within the first 72 hours. Delirium severity improved in both, with the dexmedetomidine having a superior reduction in the first 24 hours, which may indicate some tolerance developing to the dexmedetomidine. Again, these infusions were not titrated. They were set at a set dose. Patient comfort was similar between both arms, and the lack of dose escalations in both the midazolam protocol and the dexmedetomidine protocol was thought to might have led to the earlier protocol withdrawals in both arms. As we discussed, there was a faster rate of protocol withdrawal in the midazolam arm compared to the dexmedetomidine arm. All right. So overall strengths, it was a randomized trial in the end-of-life context, which as we know is very challenging to do. Limitations was that it was a small sample size, like many palliative care studies. Attrition due to death is significant. And in this case, they also had significant limitations due to protocol withdrawals, given the threshold that they had set. It was a single dose protocol, which doesn't reflect clinical practice standards. We would be titrating for effect and using breakthrough doses. The RAS-PAL scoring was done through an average of the 3 daily scores that were provided, and so doesn't really allow for assessing the continuous variability of a measure like consciousness and whether or not it's an appropriate indicator for interactivity at end of life is a good question in terms of its proxy measure. And that the patient comfort score was not assessed at baseline, so we don't actually have a comparator like we do for the delirium scale. The refractory distress was diagnosed by clinical judgment of the physicians involved in the trial and could have led to some selection bias, and whether there's generalizability is of course of question when it's primarily cancer patients. So in terms of impact on practice, and I mostly want to leave this for the discussion, in terms of the DREAMS trial itself, there's inadequate information from the DREAMS trial to draw any conclusions, but I think we might have some interesting things to think about when we look at these two papers together. So I'm intentionally going to pause there and welcome questions in the Q&A, and Jose, your thoughts as well to start us off.
Perfect. So I think what we'll do is let's jump to the comments or questions and comments that have been posted. And then I had read obviously both papers and had made some notes and some questions just for point of clarification. Just to so the dosing, Leonie, with the dexmedetomidine, the initial dosing in the Tate study, so the first study, the initial dosing was 0.2 to 0.4 micrograms per kilogram per hour. And
Yes,
the boluses were 0.2 to 0.4 micrograms per kilogram.
yes,
Yeah,
yep,
and
that's right.
then in the second, in the Dream one, I think the initiation doses were was 0.5 micrograms per kilogram per hour. So in that ballpark.
Yep, yep.
Okay.
Yeah, and in the ICU setting, I didn't go into all the detail in the background. Typically, the doses have been like zero point 0.2 to 1.5 micrograms per kilo per hour.
Okay.
Yeah.
So we've got a question here, comes from Valerie Cooper, and it relates to the first study, so the study by Tate. What did the center consider palliative palliative sedation therapy, because I think they refer to it as PST, palliative sedation therapy. Because interestingly, they don't explicitly say that that's what they
Mm,
were doing, and and I see that in their study they said 40% of those patients that were included in their retrospective study went on to receive PST, which makes me wonder why was it not considered palliative sedation therapy from the beginning? And I think that this is the question that Valerie is referring to. I looked through the paper. I cannot find a specific definition of what they used for palliative sedation therapy.
Yeah, so they don't have a definition. The only thing they reference is in the introduction where they say that palliative sedation therapy is continuous deep sedation. So I'm thinking that's why they didn't consider it part of CPST because dexmedetomidine is like the goal is to have more interactability and not be deeply sedated. So they probably had it would be good to know what their target RAS would be if they consider deep sedation, but I'm guessing at least a RAS -4. But yeah, that information's not very clear in the paper for sure.
That makes sense. Yeah, because I mean, a -1,
Mm-hmm.
a RAS-PAL. I know the RAS-PAL very well because I developed that with Shirley Bush and we published
Mm-hmm.
that in 2014.
Mm-hmm.
A -1, you can wake someone up. So it's not a deep, continuous sedation. And a -2, you could also do that. So I think about a -3, -4 would be considered deep sedation. Um, and Valerie also asked about other medications, and I think those are listed in the paper, and they include a whole slew of medications, right? Gabapentin and
Yeah.
there's also
Yeah.
ketamine and lidocaine and
Oh, it was
uh,
like, yeah, there's table two has like a giant list of everything and
yeah,
including, yeah, as you say, different benzos, antipsychotics, steroids, as you say, ketamine, lidocaine. So it gives a number of patients, but it was just a whole mix of things because it's a retrospective analysis.
yep.
Hmm.
And then Elizabeth Antefo, and I think Elizabeth is out in BC, um, asks a question related to the first study, the Tate study, the retrospective study. And her question was the possible opioid toxicity
Hmm.
the original cause of the end-of-life delirium, or did it occur because the opioid was continued during the dexmedetomidine infusion? I
Hmm.
mean,
Yeah.
I guess we wouldn't know, right?
Yeah, I don't think it's clear. There I looked at their protocol that they use for dexmedetomidine in their hospice palliative care unit, and they always recommend considering reducing the opioid dose 20 to 30% when starting dexmedetomidine infusions. So I didn't see that they had done that. But they subsequently did, obviously, in almost all patients, and then even further reduction right on day two. So I mean, that's very consistent with what's reported in the literature that you have opioid sparing effects due to the analgesic benefit, as well as what happens. Well, that's a really interesting question to get into what happens in the locus coeruleus with norepinephrine and responses to dexmedetomidine, but which may also improve some of the agitation due to opioid toxicity. So,
You actually answered the other question she had, and
oh,
that was
did I?
what does one do with the opioids? Yeah, and
Mm-hmm.
so as you said in their protocol, if I heard you correctly,
Mm-hmm.
they
20 to
suggest
30%.
reducing 20 to 30%. Okay,
Yeah.
fantastic.
Mm-hmm.
Then there is a comment from Colleen Hicks about dexmedetomidine sublingual film, but I don't think we've got that in Canada.
No,
And
never seen that.
there it says maybe not yet available in Canada.
Hmm.
So I haven't seen it, not aware of it. And then there is a question from Marco Relche. Do you know if this idea of tachyphylaxis also is brought up in other settings like ICU? When you mentioned tachyphylaxis, I thought of the midazolam. In fact, quite a few years ago, published a paper with a few cases where there was obvious tachyphylaxis that occurred, sometimes occurs quite rapidly with midazolam. So I know it does occur with some of the other drugs. Do we know if it occurs in the ICU setting?
Yes, there's some papers that do show the need for increasing dose to maintain the same effect. In the and I think also some evidence of dependency, right? So if you withdraw it quickly, then you can have a rebound tachycardia, for example. So both of those things have been documented in the critical care literature.
Good. And then Elizabeth
Mm.
Antifo comes back and says, thanks for the comments about the RASPEL, but but likely not the correct measure for interactivity. Elizabeth, I would argue that if if the way you use to measure the um, level of sedation is getting some response back from the patient, some interactivity from the patient, then yes, it is. It's not ideal, but it is an indirect measure of interactivity. I would argue. But good. Actually, I've got a question then. I don't see any other questions.
Oh yeah,
Oh,
there's one
Donna
about
Ward. There's one from Ontario. It's from
yes, and in
Donna.
fact, I actually have an answer to that question because I was
Okay.
interested in it. So I
The
don't know
question is
what,
the cost
yeah, so
comparison
the
between
question is, yes.
dexamethasone. Yeah.
So dexmedetomidine has recently been delisted and is available in a generic form now. So the cost has come down significantly in recent years. And for infusions between zero point 0.2 to zero point 0.7 micrograms per kilo per hour in a 24-hour period, it would cost between $40 to $140 for dexmedetomidine. And midazolam at 10 milligrams per hour, which was actually much higher than what was used in the study, um, would be $36 in 24 hours. So it's not dramatically different. It is still more expensive than typical midazolam, but actually the cost has come down quite a bit. So it makes it much more open to being studied and in this context.
Did you say 10 milligrams per hour for midazolam? Because
Yes,
that's a high dose, right?
yeah, that's the cost. That's just about costing. So it would be
Oh, about just costing.
$36
Okay.
a day if you were to give 10 milligrams an hour over 24 hours. So yeah, so it is, still cheaper for sure.
Yeah, because I think if you look at the literature, the dosing is
Hmm.
somewhere around zero point 0.5 to
Yeah,
6 milligrams per hour, although it
yeah,
can sometimes be a bit higher. Okay, very good. My quick question around the Tate study related to 92% of their patients, the reason was refractory pain. And I mean, that's very high because most of the other studies looking at sedation, passive sedation, pain is listed, but the more common causes, the most common indications are delirium and dyspnea. So is that perhaps because there is this perhaps observation that dexmedetomidine does have some analgesic effect?
yeah. I
I
think
mean,
so.
yeah.
Yeah, and I mean that's in pediatric palliative care and in pediatric ICU, dexmedetomidine is used because of its analgesic benefits and opioid sparing effects. So, yeah, it's pretty interesting that it was that effective.
So I was going to ask you about the second one, the dream study.
Hmm.
Quite the name
Hmm.
for the study, dreams.
I know.
But in the dream study, the abstract clearly says that this is for sedation in the context of delirium, but in the actual text, I don't think they make that explicitly clear. But I would surmise that it has to do with delirium, and it's in the title, in the dreams title as well, related to delirium. So whereas the Tate study looked at different indications
Right.
for sedation, right?
Yeah.
Um, and then in the Tate study, sorry, in the dream study, the trauma study at all, they speak about withdrawal from the protocol, and withdrawal of protocol they defined as lack of efficacy is
Yeah. So
what they
they
wrote there, right?
required, yeah, more than three
Yeah,
breakthroughs.
yeah. So for both, there was some patients where it wasn't effective. In day one, the rate was higher with midazolam, right?
Hmm.
But then both reached the same rate of protocol failure, as it were,
Hmm. Yep.
on day two or day four.
Yeah, exactly. But what's really interesting to me is that the doses were very small for midazolam. So
Exactly.
0.25 milligrams per hour over 24 hours. So the average was 18 milligrams in 24 hours. That's less than 1 milligram per hour. So for someone who has refractory agitation from delirium, that's a very tiny sniff of midazolam.
Yeah,
And
I
with
agree.
yeah,
Yeah,
and with no
yeah,
escalation, so it's not
yeah,
surprising to me that
yeah,
there was a lot of withdrawals and protocol failures in that arm for
yeah.
sure.
And that's why I asked the question because I agree with you. And I think if one looks at different protocols around the world, there is often the concept within it of titration or extra boluses so you can get control fairly rapidly. Good, thank you. I didn't see any more questions. Oh, maybe there were. Sorry, I may have missed them. Uh, oh, hang on. Marc Gorel states regarding the analgesic effect, it's only one of the treatments for opioid-induced hyperalgesia. It's also one of the treatments for opioid-induced hyperalgesia. Oh, okay, interesting. I wasn't aware of that. Um, Colleen, suspect family members of patients dying at home would prefer sublingual buccal administration. That's a very good point. If that becomes available, or if it is available, could help the challenge of undertaking sedation in the home setting. And then Kelly Honeywood answered, my experience with dexmedetomidine is in the OR, used IV in anesthesia. The significant benefits in that setting are opioid sparing, less risk of post-operative cognitive dysfunction, less post-op hangover, and patient sedation comfort while maintaining risability. Thank you. Good. So the study I would like to present is a study by Nolan and colleagues. It's entitled Practices of and Perspectives on Palliative Sedation Among Palliative Care Physicians in Ontario, Canada, a mixed method study, and that is published in Palliative Medicine Reports in 2024. The background to it is they start off the article by speaking about what palliative sedation is, and they describe it as a therapeutic intervention for the management of severe and refractory symptoms at the end of life. And they highlight in the introduction about inconsistencies in palliative sedation practice guidelines, coupled with clinician ambiguity, is what they call it, and that have resulted in confusion about palliative sedation best practices. Initially, when I saw the paper, I thought there were enough guidelines to help us with this practice, but clearly, as we're going to see in the results, perhaps that's not the case. So the research question was to explore the perspectives of palliative care physicians administering palliative sedation, including how practitioners define palliative sedation, factors influencing decision-making about the use of palliative sedation, and possible reasons for changes in practice patterns over time. And they left the terminology fairly open, just called it palliative sedation, did not, it appears, define it any further, and left it open to the participants in the study to respond. They used, in terms of methods, an exploratory mixed method sequential study. So what it means was that they first did a survey, and that survey they ended up recruiting 37 participants. These were all palliative care physicians who had practiced for 5 years or more in the field. And so they did the survey, and then they followed the survey up with semi-structured interviews. And in the interview phase, so the qualitative phase of the study, they recruited 23 palliative care physicians. Most of them were physicians who had also completed the survey. So they used the survey, I presume, to get a sense of what was happening, and then the structured interviews to do a more in-depth exploration. The study was undertaken in the first part of 2022 over a few months. They recruited the participants via the Ontario Medical Association's palliative care section list by way of invitation. And the quantitative analysis, they used descriptive statistics, while for the qualitative, they used the more traditional thematic descriptive analysis. So key results. So in the survey part, so the first part of the study, with the 37 respondents, in terms of working in palliative care, 42% of participants had been at work for 5 to 10 years. In palliative care, 26% had worked from 11 to 20 years, and 29% had worked from 21 to 30 years. So people with a fair amount of experience in practice in palliative care. The site of practice, most of them were academic centers. So by academic centers, usually it's a tertiary hospital that's connected to a teaching center, a medical school, usually. And 15 of the respondents worked in community, some worked in both. Types of the services, and again, some worked in more than one type of service, but there were respondents that worked in the home setting, others in outpatient clinics, others in inpatient consultation teams, and then there were 23 that worked in palliative care units or hospice residence units. The percentage of patients for which they initiated palliative sedation on varied. So in 73% of the responses, they provided in the previous year palliative sedation to about 1 to 10% of the patients that they had been involved in the care with. For 18% of the respondents, 11 to 20% of the patients that they had cared for, they had initiated palliative sedation. And then for a small percentage, so 6%, 21 to 30% of the patients had been initiated on palliative sedation. So you can see quite a wide variability for the majority, the almost three quarters, 1 to 10% of the patients they had cared for had received palliative sedation in the year prior to the survey. And the indications for use of palliative sedation were predominantly delirium, dyspnea, and then a much smaller number, 16 was pain, and then existential distress in a small number. When they moved over to the interviews, the mean number of years of participants working in palliative care were 12 and a half, with a range of 5 to 39 years working in palliative care. Location of practice for 9 of them was home, for 7 of them was outpatient clinics. Then there was also some working in inpatient consultation teams, and 9 working in palliative care units or hospice units. And this is where it becomes interesting in terms of the qualitative analysis. The themes that they identified were lack of standardization in practice and a lot of variability in frequency of use, the lack of standardized eligibility criteria and practice protocols. Another theme was differing definitions, where amongst these participants in the interviews, they defined it differently and indicated some challenges in terms of defining palliative sedation, especially around the area of palliative sedation as a secondary effect of symptom control, such as delirium. So you start managing delirium and then you move over, I presume, into a deep sedation. And where do you draw the line between this being management of the delirium versus in a general manner versus managing of delirium with palliative sedation? They identified logistical challenges, including community practice and importantly, lack of familiarity with what palliative sedation was amongst especially teams that were not palliative care teams. So these would be different units in an inpatient hospital setting, and I presume in the community as well. Another theme was the increasing perception of palliative sedation being a backup to MAID, to medical assistance in dying. So a loss of distinction between MAID and PS and palliative sedation was described by some. And then they also mentioned how it also depends on who the MRP is in terms of initiating palliative sedation, with differing patterns, whether you're, not surprising, a palliative physician versus not a palliative physician. So the key discussion points brought up by the authors was the lack of uniformity and inconsistencies in palliative sedation practices, especially around frequency, definition, timing, and application. Variations in terminology. They identified things like intermittent versus continuous, or the use of respite, proportionate versus continuous deep sedation, terms such as rapid induction. So all these terms popped up, and there did not appear to be a uniform understanding of these. Disagreements over the use of medications with sedating side effects, as I mentioned before. The prevalence of palliative sedation varying widely across care settings and jurisdictions. In the discussion, they mentioned that across the world, different studies have looked at prevalence, and there's been a very wide prevalence or incidence of palliative sedation described. Some of it could be attributed to varying definitions being used in different jurisdictions. They do highlight that local guidelines can result in improvements to clinical practice, but do say that inconsistencies with respect to recommendations about timing of initiation of palliative sedation, medication protocols, and approach to artificial nutrition hydration was a problem. So strengths, I like the mixed methods approach. They described very well the qualitative analysis that they did. Limitations that they identified was this is restricted to Ontario, and therefore in other jurisdictions could be different, particularly if there are protocols well established in other jurisdictions. What I found was they didn't describe here was the researchers' reflexivity, because in this particular topic, especially with researchers who do provide palliative care as well, um, it'd be important to be very aware of your own biases, your own practices when analyzing qualitative data. Impact on practice, they really highlighted the need for great educational resources, the interventions on palliative sedation, both in palliative care teams, specialist teams, as well as non-palliative care teams. And that was the paper. So I don't know if there's a lot of time for discussion, but I must say I went and looked at the history of palliative sedation in terms of guidelines. And over the years, starting way back in the early 2000s, there were a whole lot of protocols that had been identified, and there'd been one as well for Canada back in 2014, for example, that provided definitions, provided practice guidelines. And there's also been a more recent one from the European Association for Palliative Care, and that was published as recent as 2024 in Palliative Medicine. So, taken by surprise with these results.
Yeah, I will. I know we don't have a lot of time for discussion. I was too, and I wonder if it's actually an issue of education and awareness, and um, if there would be a difference between those who have trained in specialist palliative care versus those who have not, because it's certainly part of the competencies for the Royal College program. And having recently written a chapter on palliative sedation and reviewed all of the protocols in Canada are all very similar and are based on the framework for continuous palliative sedation that was put forward by the Canadian Society of Palliative Care Physicians,
Mm,
now the
mm.
Society for Palliative Medicine. And there's a recent update from CSPM regarding recommendations of standards around palliative sedation, including that it shouldn't be used for existential suffering, for example, and specific protocols that are recommended. So yeah, I was a bit surprised, and I wonder if it's more education and awareness that needs to be standardized for the people who might be using palliative sedation.
Yeah, my sense is education, but I can also understand why some terms such as intermittent sedation may confuse where is that palliative sedation or not. I still, in my clinical practice, turn to the definitions, for example, that were written up by Nathan Cherney and colleagues back already more than 10 years ago. That palliative sedation refers to the intentional the practice of intentionally inducing reduced level of awareness. Having said that, I guess there can also be confusion with if we define it as sedation with the intention of the lightest level possible at the lowest dose possible. And if that's what we're doing and folks are still awake, which often happens, is that palliative sedation or not? So I can understand why some of this confusion is coming up, and we just have taken it for granted that there is some homogeneity in understanding, but perhaps not. Oh, curious about questions. Okay, so let's
I'll
go to the
answer
last
the
one.
other questions online.
Perfect, thank you. So the last paper is different. Now we're jumping to a different topic, but I would say as important, and it relates to caregivers. And it's a paper by Arias Rojas and colleagues out of South America. And the article is entitled Efficacy of the Palliative Caregivers Intervention for Caregivers of Patients with Cancer in Palliative Care. And so the background was they highlighted the importance of caregiving role. And by caregiving, they specifically referring to what we sometimes some people refer to as informal caregivers, although I think they are formal, but in the sense of family members, friends, etc., providing care. Uh, and they highlighted how many caregivers have no preparation to take on this role, no training, no preparation. So they asked the question about the how effective is an education program that they had developed, a program called Palliative Caregivers, designed to educate caregivers of cancer patients on and specifically around the areas of providing care, managing symptoms, and also caregivers caring for themselves. So this was a study in Colombia, specifically at a cancer center in Medellin. Um, it was a randomized controlled trial that they undertook over 7 months in 2022. The participants were informal family caregivers of adult patients. So they excluded patients who were the caregivers of patients who were at the very end of life, that is, the last days of life, if they could predict that or try to predict it. And they also excluded paid caregivers. They did a one-to-one randomization. And interestingly, the participants and the researchers who were collecting the data were blinded to which intervention the caregivers were arm, whether it's the intervention arm or the control arm. So in the intervention group, they received the palliative caregiver course. The control group received usual care, and that was a face-to-face assistance of about 20 minutes to 30 minutes information just prior to the patient or while the patient was in hospital. So it looks as though that the caregivers were caregivers of patients that had been hospitalized. And the intervention arm, the palliative caregivers, is a two-session face-to-face teaching session where in the first session was about half an hour. They provided the caregivers with these resources, a package, an information package. They orientated them to it, and then they came back and over an hour and a half, went through this package in detail. There's a very good description in the article about what the components of this education, of this intervention is. They used various measures to assess the impact, and it included a caregiver's role, and they used the ROL tool. They used the MOS Social Support Survey for support, which I found a bit strange because it is self-reporting that's been validated for patients. And I couldn't find any study that looked at the use of MOS for caregivers. They also explored caregivers' quality of life using an instrument called the Quality of Life in Life-Threatening Situations, a family version. They collected data at baseline, which is T1, 2 weeks post-training, T2, and then 4 weeks post-training, and that was T3. And they did a whole calculation as one normally would do in terms of what sample size you need. Just very quickly, the results. The completion rate, there was a lot of attrition. The completion rate at T2 was 48%, 58 in the intervention, 57 in the control, and in T3 it had fallen down to 29%. Um, I'm not going into the details of the participants, but on average, the mean age was 44. 79% of the group were female. Interestingly, 38% of the caregivers were parents, 24% were partner spouses, 23% were friends, and I didn't see on the list children. So looked pretty smaller. 35% of the participants had a high school education. For the patients, the mean age of the patients was 58, and their Karnofsky score, which is quite similar to the PPS, was 60. In terms of role adoption at T2 and T3, the intervention group appear to have adopted their role better. In terms of social supports, recognizing the limitation, as I said earlier, that the instrument was more for patients, not for caregivers, but it was higher in the intervention group at T2, but no difference at T3. And in terms of quality of life, there was with the overall measure of quality of life, there was no difference between the two groups at T2 or T3, although when they looked at subdomains of quality of life, there were higher carer's own state. So that meant things such as the caregiver's sense of burden, the caregiver's sense of distress. At T2 and T3, there were higher scores, so better coping with that role at T2 and T3. There are some limitations, as usual, with the study. One of the things was, in addition to the attrition, was also that at T2, when they went to see the caregivers, for some of them, the patients, their loved ones, their friends, were still in hospital. So it's difficult to do that assessment when they haven't had an opportunity as such to apply what they learned. At the end of the day, I think why I found the study very useful was that it highlights the importance of training and supporting caregivers for the role. I don't think it gives a final answer on what that education and their training and their preparation looks like. The authors in their discussion do highlight that previous studies that have looked at this and previous literature suggest that short interventions, when needed, so just in time, short interventions are perhaps the most effective. Um, but I think future work of research should look at that. Again, the important thing is highlighting the importance of training caregivers and preparing them. So I'll stop there. I know we're over time and I apologize for that. I'm sure some of you will have to leave. If there are any questions, any comments you'd like to make, Leonie?
No, I think it's a interesting tool that will be helpful, as they say, especially in more resource deplete settings, as a way to really bolster some confidence and comfort level with families. But yeah, I look forward to seeing more on it. Mhm.
Yeah, I think this one was more about a combination of giving resources because it included an app actually
Mm, mm,
in the resources they give, plus some face-to-face instruction and orientation. I guess in the future we should also look at studies at what if you gave online or virtual information, online resources only that takes the caregivers through it. Is that effective or not?
mhm.
Good. So that was it. I don't see any questions. Oh, Lynn Meadows. Lynn, nice that you've joined us. Short intervention is a start, but caregivers are already so overwhelmed. And I know you're speaking from experience as well. So thanks for adding that comment. So our honorable mentions, we thought this time we would intentionally focus on the area of palliative care in respiratory illnesses. And so there's a paper by Corsi et al., Interventions to Address Supportive Care Needs of People with Pulmonary Fibrosis. And this is a scoping review. If you're seeing patients like this, I would really recommend you to read this article, very interesting. There's an article on cough and dyspnea management in pulmonary fibrosis. There is an article by Holland and colleagues on evidence-based management of symptoms in serious respiratory illness. What is in our toolbox? Again, a nice overview of with a lot of clinical tips. And then lastly, an article by a group looking at specialist palliative care consultation for patients with non-malignant pulmonary diseases, a retrospective study. So again, this will be posted. This will be sent to you, that the presentation, so you'll get this soon through your emails, and it will then be made available within the next few weeks on the website. And the podcast we hope to be coming out in about 1 to 2 months' time. Thank you very much for joining us, and do promote this to your friends. I think now it's 4 years, we're into our fifth year now. Let's promote it, let's push it, use it. Feel free to use this as part of your work, and feel free to share this with the teams, and even perhaps use this to have some discussions in-house within your respective teams. Just thank you to all of those who monitor the article, the various journals, and submitting always to the Journal Watch and to the Pallium support team. Thank you very much for all the support, and thank you, and see you next time in about 2 months' time. Thank you.